name is Dr. Shamoon, and I'm presenting a case report on methamphetamine-induced lung injury with acute rhabdomyolysis. Methamphetamine abuse continues to pose a significant public health concern worldwide, with its devastating consequences extending beyond addiction to encompass severe physiological repercussions. This review explores the intricate interplay between methamphetamine use, lung injury, and rhabdomyolysis, shedding light on the multifaceted pathophysiological mechanisms underlying these conditions. Methamphetamine-induced lung injury, characterized by pulmonary edema, inflammation, and acute respiratory distress syndrome, represents a complex manifestation with potentially fatal consequences. Concurrently, the development of rhabdomyolysis, marked by skeletal muscle breakdown and subsequent release of myoglobin, presents additional challenges to clinical management, including acute kidney injury and electrolyte disturbances. Understanding the intricate pathogenesis of methamphetamine-associated lung injury and rhabdomyolysis is paramount for timely diagnosis, effective intervention, and improved outcomes. Methamphetamine-induced lung injury is becoming a widely recognized entity, and several case reports and observational data have emerged that describe the various lung injury patterns associated with it. Here we present a 38-year-old male who was admitted to the ICU in an obtunded state with acute hypoxic respiratory failure due to methamphetamine-induced lung injury, and dramatically improved with ventilator support. This patient is a 38-year-old male with a pertinent past medical history of substance abuse who presented to the ED with a chief complaint of altered mental status. Patient was found to be hypotensive, hypoxic with no initial leukocytosis. Patient was placed on venti mask and fluid resuscitation was done. Patient was transformed to intensive care unit for close monitoring, started on empiric antibiotics. The chest X-ray, which you see on the right, was concerning for possible volume overload, and troponins were markedly elevated to 2.8. Initial labs was also revealed to have a CK of 27,000, which improved to 8,000, roughly around there, after aggressive IV fluids. Overnight, patient's mental status continued to improve, but he continued to require supplemental oxygen. The CTs that you see on the right of the chest revealed a ground glass infiltrate of the upper lobes centrally and the superior segments with interlobular septal thickening. After the patient was more responsive, he endorsed smoking methamphetamine prior to this incident. The urine tox was positive for amphetamine. The elevated troponins were ultimately suspected to be secondary to acute hypoxic respiratory failure. Given the fact that the EKG was negative and for any ischemic changes, an echocardiogram revealed normal LV function. The patient's respiratory status continued to improve with antibiotics. He was eventually weaned to room air. He was heavily counseled on cessation for recreational drug use. So for the discussion portion, the clinical scenarios of methamphetamine-induced lung injury include non-cardiac pulmonary edema, acute respiratory distress syndrome, alveolar hemorrhage, and pneumonia with pneumoconiosis. Due to its lipophilic nature, it is rapidly absorbed into the nasal mucosa, metabolized into active amphetamine, creating high blood concentrations, leading to more toxic effects as compared to oral or IV use of methamphetamines. Studies done on mice offer free radical generation and its toxic effect on the long parenchyma as a plausible explanation. Exposure to 100 milligrams of methamphetamine significantly increased the free radical generation of the bronchoalveolar lavage cells to 107 to 146% of controls and to approximately 135 of the controls in lung tissue in situ. In addition, the methamphetamine's effects of autonomic nervous system and stimulates the secretion of serotonin, dopamine, and norepinephrine, which leads to tachycardia, hypertension, vasospasms, myocyte injury, and ultimately myocardial infarction. These effects of myocytes can induce seizure, repetitive muscular activity, and hyperpyrexia, which include dopamine stimulation that can cause rhabdomyolysis. In this report, we discussed the case of methamphetamine-induced acute hypoxic respiratory failure requiring mechanical ventilation, in which the patient improved significantly. My references are located below. Thank you so much.